Well, good evening, everyone, and welcome to tonight's virtual presentation hosted by Northwestern Medicine Living Well Cancer Resources. We're so glad you guys could join us tonight for Common Breast Cancer Myths Debunked. This evening, we're joined by two incredible speakers from Northwestern Medicine, Dr. Angela Miciura, breast surgical oncologist and medical director of breast health in the Northwest Suburbs, and Tucker D. Benjamin, physician assistant and registered dietitian. As a reminder, please just make sure to keep your mics muted during the presentation, but if you have any questions that come up throughout this, just feel free to drop them in the chat below at any time. So please join me in welcoming Dr. Miciura and Tucker Benjamin.
Hi, everyone. Yeah, thanks so much for allowing us to kind of talk to everybody. I think, with the month of October, it's always just another reminder and what we can do to raise breast cancer awareness. And so thanks for Living Well for allowing us to do this tonight. So today we are going to talk a little bit about just some common breast cancer myths and why they may or may not hold a lot of weight. So that's me, that's Tucker. This is our two offices. So I am based in the Northwest region. So as everybody maybe knows, Northwestern, the way they kind of organize their health systems is by region. So there's the North region, there's the West region, I think there's a South, maybe there's Orland Park Hospital, and then we're in the Northwest. So we mainly cover the Huntley Hospital and McHenry Hospital, and then we have two office locations, and so one's in Crystal Lake and one's in Algonquin. Okay, so some of the topics that we're going to cover today, we're going to talk a little bit about breast cancer signs and symptoms, a little bit about breast imaging, some statistics, risk factors, and things that we can do to modify our lifestyle. And so the four myths that we're going to talk about are breast cancer will always cause a lump you can feel, men can't get breast cancer, eating soy will cause breast cancer, and there's nothing you can do to prevent breast cancer. So starting with the first myth, breast cancer will always cause a lump that you can feel. So this one will kind of get broken down into two parts. Really, the first being that there's a lot of times you feel something in your breast. It doesn't always mean it's cancer. And then on the flip side, a lot of times you don't feel anything and cancer is identified on, say, a screening mammogram. Okay, so let's start with a little bit of some possible ways that breast cancer can present. So it can present as a new lump or a breast in the breast or maybe in the armpit. You can get some skin changes, so either itchiness or redness of the nipple area, thickening of the skin, tethering or dimpling in the skin. We can see changes to the nipple. And so most of the time, like nipple inversion. So some people have this, they're born with this, it's both sides. It's oftentimes the change in the nipple. And so when there's a cancer inside and it pulls the nipple in, that's what we see. Sometimes you can just feel more fullness in the breast or pain sometimes, or nipple discharge. But there are a lot of reasons that we can feel masses in the breast, though. So there's a lot of non-cancerous bumps in the breast. So some of these, this is just listing some of the possibilities. So you can have cysts. So this is just fluid-filled sacs or parts of the lobules of the breast gland. You can have an abscess. So this is an infection, which is filled with, bacteria and pus, essentially causing like something you can feel. Fibroadenomas, this is a benign tumor of, I guess, like the connective tissue that's in the breast. Oftentimes, younger women will feel these. We can have them as older as well, but these are fibroadenomas. There are lymph nodes everywhere in the body, including inside the breast sometimes, that can cause something you can feel. Lipomas also, this can happen anywhere in the body, but we can also see this in the breast where this is just an extra growth of the fatty tissue. A galactocele is something that we more often see in lactating women or people who have just finished lactating. And this is, again, like a little collection or cyst-like, but that's filled with milk. And then hamartomas is kind of similar to fibroadenomas. It's a little bit different, but again, it's just like a abnormal growth of kind of some of that connective tissue in the breast. And so the take home here really is that There's a lot of things that can cause a bump, and it doesn't always mean it's cancer, but it is important to know that if you do feel something, you really should let your doctor know, because then that way they can do an exam, they can evaluate it and see if there's any more imaging that they need to do, really to make sure that it isn't something. Okay, so don't just ignore it, but know that there's a lot of reasons why you could feel something. Okay, so now we're going to kind of shift gears and talk a little bit about, well, what about it's the cancer that you can't feel? And so this is where the breast imaging really comes into play, specifically the mammogram, right? Everybody kind of knows you start your mammograms at 40. And so a mammogram, what it really is it's just it's kind of a specialized x-ray of the breast. We do know it's the best way to find cancers. It can find things early. Most commonly now we are doing the 3D or the tomosynthesis, where maybe back in the day it was mostly just the 2D. And so the way they work is you take the pictures in two views, right? And so a little bit to talk about, I think here is the difference between, say, a screening mammogram and a diagnostic mammogram. And so the screening mammogram is a woman who doesn't have any complaints, and it's really just their routine. I do this once a year and I go and get my pictures. And so the tech is going to be there with the patient. Again, you take the compression in two views, so they're squeezing it in two different ways because it's a 3D object. And so you have to have the two different views in order to recreate that. And then you go home and then the radiologist is reading it basically once the patient's already at home. And so this can be where sometimes people need to get called back for a recall. Doesn't necessarily mean something's wrong. It just means that they only have these two pictures and they need to take a look and take some more pictures. Okay, so this is a little bit different than when we say a diagnostic mammogram. So a diagnostic mammogram is when you have a complaint. So you say, oh, I feel something, or I'm having nipple discharge, or I'm having pain. There's some reason why you're getting the mammogram. And now the way the diagnostic works is you show up, you take some pictures, but the radiologist is there looking at it and they're telling the tech, okay, I want some more views here. I want, some compression views. I want some magnification views. Or sometimes if they see something, they say, well, I want an ultrasound. And so this is all done at the same visit, and the patient doesn't go home until they have, it's kind of like the report, but it's essentially that the radiologist is kind of saying, this is what we're seeing and this is the recommendation. And so oftentimes, like I kind of alluded to, if you have a screening mammogram and they do see something or they identify something, they will then call the patient back to get the diagnostic. So when you come back, you're now in that diagnostic where the radiologist is telling them all the pictures to take to fully evaluate what's going on, okay? Okay, so what are some potential things that we can find on the mammogram? And so for the most part, again, the mammograms are x-rays. So it's going to find things based by density. So things that are more dense. So that's masses oftentimes will show up. Calcifications. So calcifications are small little calcium deposits. We could probably spend a whole hour just talking about the different types of calcifications that we can identify in mammogram. So some of them are and it's all based on the pattern, right? So are they grouped? Are they linear? Are they in this type of distribution? Are they big? Are they small? How all of those different things kind of puts it into picture of how the suspicion for the radiologist. And so, like I said, some can look very benign and they don't even need to take more pictures or follow that or anything like that. And then there are others that look more suspicious based on these groupings or things that they see. And then there's kind of this in between also. And so really the threshold for further workup or biopsy that we talk about is actually quite low because we don't want to miss a cancer. And so the suspicion has to be 2%, right? So anything that's over a 2% risk that it could be cancer, they're usually going to recommend a biopsy. And so just because you need a biopsy, say, for example, for calcifications, also doesn't necessarily mean it's cancer. So there's a lot more we could talk about calcifications, but I think that's kind of the bulk of it. There's a few other things that they can identify on mammograms. So architectural distortions, this is just kind of where the tissue looks a little bit different. And then an asymmetry. So they're comparing now, right? Remember, you're taking two views and they're comparing the views to each other, but then they're also comparing, say the left side to the right side. And so they're saying, hey, there's an asymmetry in the way this is looking. And so most of the time, these findings are going to prompt a callback to take more pictures and fully evaluate things. Okay, so there's other parts of the imaging, like I kind of mentioned, an ultrasound. Oftentimes, if you see a mass or if you see, usually this is not performed for calcifications, but it is often performed if they see like a distortion or an asymmetry or a mass for sure. Or if you feel something in your breast, oftentimes they'll get an ultrasound. And this is just one other way to take a look at the tissue. And so that's what this picture with the red arrow is showing. So that's kind of that irregular, it's not very round. It's not really nice and circumscribed. It's kind of scalloped and spiculated. And so that's kind of the cancer on the ultrasound. And then the other test that we do is an MRI. And so this is a breast MRI. It was introduced actually in the 80s. It's becoming very much more popular now. And a lot of times, even when we talk about screening, which we'll get to, it is replacing the ultrasound when we talk about screening things, because it is just so good. The way it works and how it finds things is different than the mammogram. The mammogram is finding things by density. This is finding things based by blood flow. And so it does require contrast. So that's another question that we get oftentimes is, can I get my breast MRI without contrast? I don't want the contrast. And the answer is really like, no, because the purpose of getting the MRI is to really highlight that blood flow, because cancer needs blood flow. And so that's where it shows up. The good thing about MRI is that it's really good at finding these cancers, but then it's also really good at finding everything, right? So anything that would have a little bit of extra blood flow, which doesn't necessarily mean that it's a cancer. And so there is the potential for false positives. So that's what we call false positives, is it shows something and now we need to biopsy that. And it turns out to be nothing, but did we really need to find it in the first place if it ended up being benign? And then this is just more of a technical aspect that unlike some like other MRIs where you're on your back, for your breast MRI, you're actually on your belly and your breasts are kind of hanging inside of the coil that then takes the pictures. Okay, so when we talk about how are we using the MRI, I would say one of the main points right now that we're using this is for supplemental screening for women who are found to be at high risk for developing a breast cancer. And so supplemental screening just means in addition to, right? So you always still need to have your mammogram because they find things differently. It's the combination and the synergistic effect of them. So that's why it's supplemental. And so some of these women who can be classified as high risk is anybody who has a calculated risk over 20%. Usually this risk can be calculated. It can be calculated by anybody, your OB-GYNs. I don't know if primary cares, in theory, they could do it. Oftentimes when you're getting your mammogram, this is getting calculated and put into a report if it is found to be over 20%. We also do it as part of our high-risk breast clinic, or any high-risk breast clinic that you go to will also calculate your risk. Also, if you've had a biopsy in the past that has shown atypical cells, whether it's atypical lobular hyperplasia or atypical ductal hyperplasia, and then also people with strong family histories or women with dense breast. And we're going to get into the dense breast in a little bit. The other way we use MRI a lot is if you've been diagnosed with a breast cancer and we want to evaluate further, then we'll also use it to evaluate silicone implants. So this is actually that MRI, I guess that's the only MRI that's done without contrast, because really you're actually looking at the implant and you're not looking for cancers, okay? But this is still another way to use MRI. We will often use it for women who have breast cancer who are undergoing chemotherapy before surgery. So we use it before treatment, after treatment, and then you can assess the response. Or if there's other problems that say, you know, like suspicious nipple discharge, that your mammogram and ultrasound are negative, and this is one more way to make sure we're not missing something that's very small that isn't showing up on a mammogram. Okay, so let's talk about breast density. And so women will usually get this category, they get assigned a category on their mammogram. And this is done by the radiologist or the, I guess, the machine also in tandem. And so there's 4 possibilities. Okay, so there's A, B, C, and D. And so you can kind of see in the picture there, the differences. So the one on the far left is A, the second one is B, the third one is C, and then the fourth one is D. And just to note, sometimes this category can change. Okay, so most younger women will have dense breasts. And as we go through menopause, where your estrogens get lowered and they drop, your breast can become less dense. So it is somewhat mediated by our estrogens. And so category A is mostly fatty breasts. And category B is mostly fatty, but there is still some scattered areas of the glandular tissue. But both of this grouping, A and B, are considered not dense, and that's about 50% of women. And then the C and D category are considered dense, okay? And so in the C category, this is women who have these, I guess they're kind of bigger pockets of dense breast tissue. It's called heterogeneously dense. And that's about 40% of women. And then category D, so that's the most dense, it's extremely dense breast tissue. That's probably about 10 to 15%. And so you can see, I mean, based on the mammogram, right, that in the extremely dense category, it is helpful to have a different way to find cancer with blood flow, with the MRI, and that's how it's useful. I find it especially useful in category D. It can be useful in C, but I think that one's more of a discussion to have and kind of a multifactorial reasons, okay? Okay, so this is just a little summary. So a lot of our guidelines, this is the ASBRS, which is the American Society for Breast Surgeons. So a lot of, as a breast surgeon, is what we use when we talk about some guidelines. And so this kind of breaks it down into a couple of different categories. I think that the top 2 here are women who are at average risk, and that gets splits up into people with dense breast tissue and not dense. Regardless, average risk, you're going to start your annual mammogram at 40. Okay. And then the question becomes then for density, do we need to talk about adding an MRI? And this is something that is a little bit more individualized. I can't say everybody with dense breast tissue should get the MRI, but I think it's worth a discussion. And then the other category, again, is those with higher risk. And so one can be a reason if you have genetic testing and you're at higher susceptibility, or, you know, some women who've had, or I guess some people who've had radiation as a kid to treat lymphomas are at an increased risk. These really should start having MRIs at age 25 and then the mammograms at 30. And so the reason we start MRIs sooner is because it's not based on density, right? And so at 25, you're not going to, the mammogram isn't going to be very helpful because it's really dense for the most part. And so mammograms would start at 30 in those patients. And then kind of similar or along those lines also would be those who have that lifetime risk over 20% or strong family history. So we know that they're at increased risk, but maybe not as high as this other category that I mentioned. And so these will still get their annual mammograms and then can talk about the supplemental with an MRI. And this would be starting at about 35. Or the caveat is if you have like a close relative, like a first degree, so mom, sister, and you would start 10 years sooner than their diagnosis. So if your mom was 40 when she was diagnosed with breast cancer, you should start your screening at 30, okay? And then the other 2 are maybe a little less applicable to this group, but if you've had a history of breast cancer and you were younger than 50, then you would have your mammograms. Sorry, that says older 50. you would just have your mammograms. But if you're younger than 50 when you were diagnosed with your breast cancer, or you have dense breast tissue, you should probably get the MRI in addition to the mammogram. Okay, these are just some statistics in the setting of 1 in 8 women really will get a breast cancer in their lifetime. And we know that the 5-year survival rate for, say, a DCIS, which is one of these non-invasive localized breast cancer, is 99%. And so this just highlights the importance of staying up to date on your screening mammograms. So just to recap, get your mammogram every year. So back, there used to be some kind of discussion on every other year, or, you know, the timeline, but really for the, I think both the Radiology Society as well as the Breast Surgeon Society, we recommend annual mammograms. So getting your mammograms every year. Okay, and then the second one is, if you feel something, it might not be a cancer, but you should tell your doctor and still get it checked out. And then again, get your mammogram every year. Okay, so now we're going to shift gears a little bit. Myth number 2 is that men cannot get breast cancer. And so we know that that's not true. However, it is rare. Okay, so there's about 2,650 annual cases of breast cancer. Male breast cancers account for less than 1%. And a lifetime risk, when we talk about men versus women, in men, it's about 1 in 1,000, whereas for women, it's 1 in 8. Okay, so quite different there. But the incidence rates increase steadily with age in men, like they do in women. But the average age is a little bit higher, the average age of diagnosis is a little bit higher in men than it is in women, and it's about 67. When we talk about like pathology, and so the male breast cancers are more likely to be the estrogen positive. It's less likely to be HER2 positive, and it usually is an invasive ductal carcinoma. But compared to female cancers, male breast cancers occur later in life, usually with a higher stage, higher grade, and we do see more of that estrogen receptor positivity. Racial and ethnic differences also occur, though. So Black men have a higher incidence of breast cancer than, say, non-Hispanic white men. And the lowest incidences in Hispanics are in Hispanics and Asian Pacific Islanders. So there are several risk factors that are associated, including demographics, environmental, endocrine, and genetic factors. And so most of these conditions are associated with increased estrogen levels, we know are associated with increased risk of developing breast cancer in men. So this can include gynecomastia, so this is glandular proliferation in a male, liver disease, and also obesity. Also androgen deficiencies and testicular abnormalities can also be contributed. And so there's also this environmental and radiation exposure. So kind of what I was talking a little bit about after radiation. So this was a study that looked at male breast cancers from 1973 to 2012. They found that there were 464 cancers that were identified basically as secondary primaries. And so they found a significant association with those who had lymphoma first. And so the thought here was, you know, the radiation for lymphoma, you often get mantle radiation, which is kind of across the whole chest, up to the neck and down. And so the thought is that this mantle radiation delivery that's often used as a treatment for lymphoma plays an increased risk, plays a role in increased risk for men developing breast cancer. We also see it for women too. So when we talk a little bit about the genetic disorders also, so there's kind of one, which is the Klinefelter syndrome. So this involves inheritance of an additional X chromosome. So they're actually XXY. These patients typically have atrophic testes, gynecomastia, high levels of these hormones like FSH and LH, but low testosterone. And so the breast cancer risk here is hypothesized to be basically the high ratio of the estrogens to the androgens, which leads to proliferation in the breast, in the ducts specifically. We also know that men with breast cancer have higher likelihoods of carrying the BRCA mutation. And so BRCA1 and 2 are the most clearly studied risk factors for male breast cancer. And when we break it down to BRCA1, we see about 1 to 4%, with BRCA2 being a little bit higher and about 4 to 16%. So the guidelines recommend genetic testing be offered to all men who develop breast cancer, and even in women who have one family member with male breast cancer, which should also undergo genetic testing. So this is just a little bit about breast cancer screening in men who have either the BRCA1 or the BRCA2. So we know starting at age 35, male BRCA carriers should have a clinical exam every year with the physician. Mammograms are kind of more on an individual basis, so they don't necessarily need to have mammograms. There's no real role for screening mammograms in these men. And there's also no role when we talk about, preventative mastectomies. We don't really talk about that in men with the genetic mutation. But we know that these men are also at higher risk of developing other cancers, including prostate and pancreatic. And so like average lifetime risk for prostate cancer in someone is about 14%. But for BRCA1 and 2, you can see that it's much higher. It's about 25 to 50%. They're also at higher pancreatic cancer risk. So 2 to 3% for those with BRCA1, 3 to 5% with those with BRCA2, compared to just 1% that's in the general population. So it's almost 2 to 5 times more. It's also associated, BRCA2 specifically is also associated with a higher risk of melanoma. And so those patients should also have full body skin exams every year. So some warning signs of the male breast cancers. Oftentimes in men, cancer presents behind the areola, behind the nipple and areola. So that's oftentimes where you'll feel a mass or thickening of the skin. About 40 to 50% actually involve the nipple itself. You can also see as like kind of similar to women where you can have an itchy rash, you can have an inverted nipple, you can have nipple discharge. You can also feel kind of a mass in the axilla also. So when we talk about treatment for men, a lot of our management is actually extrapolated from what we know and how we treat female breast cancers and the studies that we have. A lot of the studies that we base that on really didn't include a lot of men. And so when we talk about surgery, it kind of depends on the location of the mass. Like I said, most of the men's glandular tissue is located kind of behind the nipple. But depending on where the mass is, you can either have a lumpectomy or sometimes we need to do a full mastectomy. And then we would also sample the lymph nodes kind of like a female. And then after surgery, when we talk about adjuvant therapies, sometimes it includes radiation. And then since most male breast cancers are hormone receptor positive, endocrine therapy is actually an important treatment option. So this is typically with tamoxifen. And so that's kind of like a pill that essentially blocks the estrogen from binding to certain locations, specifically in the breast. And so it's a pill that they take for 5 years. Side effects of the tamoxifen in men is similar to those in women. So that can include mood changes, sexual dysfunction, hot flashes, and a small risk of blood clots. And so when we talk about surveillance, so how are we monitoring patients after their breast cancer diagnosis and treatment? And again, similar to kind of how we deal with women, I would say the one difference is that we really don't know the role of mammograms, of continuing to do a mammogram. Obviously, if they've had a mastectomy, they don't need mammograms on that side. But if they've had a lumpectomy and there's still maybe some breast tissue, do you need to do a mammogram? And that's a question. And the same thing, what about the other breast or the other side? We know that the rates of that is very low, of having a new breast cancer on the other side. And so really, as of now, there aren't any guidelines. So it's mostly just a discussion to have with the patient, or that the patient has with their doctor, I should say. And then when we talk about prognosis a little bit, in general, men actually have lower adjusted rates of overall survival than women. Now, some of this difference can be kind of explained by, well, they're presenting at a more advanced stage. Maybe they're a little bit older when they kind of come with cancer, or men in general have shorter life expectancies than women. So these are just some ideas behind that. Over time, survival rates have improved really for both men and women, but really that improvement for men has lagged behind. Okay, so that's all done with my part. Thanks for your attention. I'm going to shift this over to Tucker to talk about our next 2 myths.
Starting with eating soy and breast cancer. So this myth has been around for a while, but we still get questions about it. So where did this come from? So soy contains phytoestrogens, specifically isoflavones, which are plant estrogens, and high estrogen levels are associated with increased risk of breast cancer. So naturally, it was thought that eating soy could increase estrogen levels. So there, decades ago, early studies with mice and unnaturally high levels of isoflavones were shown to increase the growth of estrogen receptor positive breast cancers. However, we are not mice, and humans metabolize isoflavones very differently. And phytoestrogens or plant estrogens are structurally different and much weaker than human estrogen. They bind to estrogen receptors on breast tissue differently than human estrogen, so they don't have the same effect. We have over 20 years of evidence that show no consistent increased risk of soy foods and breast cancer. And in fact, moderate soy food intake may actually be beneficial. And this is related to likely the antioxidant and anti-inflammatory effects of soy food. And also there's beneficial effects on bone health by mimicking this protective estrogen-like effects. And they also can provide a good source of protein, calcium, and fiber. So one thought of how soy may decrease the risk of breast cancer is that the phytoestrogens can decrease aromatase. And aromatase is an enzyme that converts androgens to estrogen. So the phytoestrogens bind to aromatase enzymes active site, decreasing their activity and downregulating gene expression, reducing the production. So some other, aside from soy, some other important dietary phytoestrogens include flaxseed, resveratrol, which can be found in red grapes or wine is probably the most commonly known, but also in blueberries, cranberries, walnuts, cocoa. There's also a lot of phytoestrogens in green tea, matcha being one of my favorites. So if you are going to eat soy, it's important to include the whole food sources. So examples of this would be tofu, edamame, tempeh, miso, unsweetened soy milk. And tempeh and miso are fermented, and so they actually have the highest isoflavone amounts. But again, focusing on whole food sources rather than processed, because that's where the research is supporting the benefit. Rather than more processed soy foods like soy protein isolate. So the final myth, this is the bulk of the presentation, is on breast cancer prevention. So a lot of people think they can't do anything to reduce the risk of breast cancer. So there's this hereditary misconception that many people believe that breast cancer is primarily an inherited disease, but actually most cases occur in women without any genetic or family history. So we break down breast cancer cases into 3 kind of categories. So sporadic being the most common, that's over 80%, where you don't have any family history or inherited genetic mutation. The smallest group would be the hereditary, where there's a clear genetic mutation that can be identified, such as like the BRCA1 or 2. There's also the familial category, which is the hereditary, which is a combination of genes and environmental factors that may be involved in your risk. So Dr. Miciura already kind of went over a little bit of BRCA1 and 2, and that's this is the smallest subset or category of patients being identified as high risk, having a genetic mutation. And BRCA1 and 2 are probably the most common. They are the highest penetrance mutations. So with over, depending on your source, around 60% plus lifetime risk of developing breast cancer. The others that I have on here, also well known. Back in 2013, the high-risk breast panel included these 9 genes with the greatest lifetime risk of breast cancer. Now the panels are including over 20 genes that can be associated with your increased risk of breast cancer. But then there's also the subgroup of the familial history. So you may not have one of these genes, but you have multiple family members that have had breast cancer. Another strong family history, if you have maybe just one person, but they were diagnosed at a very young age, or Ashkenazi Jewish heritage also confers increased breast cancer risk. So I want to focus mostly on sporadic breast cancer because that's the most common, and that's where a lot of people, you can have some control over your risk. And this is caused by a series of genetic mutations over time, but there's multiple factors and a lot of them being studied, a lot new. We don't know a lot, but there are some documented, like radiation exposure, certain chemical exposures, hormonal factors, and then diet and lifestyle. So I want to focus mostly on the modifiable risk factors because rather than the non-modifiable factors, but just to know there are many. So some non-modifiable factors, just being female, being Caucasian, the older you get, the higher your incidence or chances of getting breast cancer are. If you have a personal history of certain breast conditions like atypical hyperplasia, like ADH, ALH, or LCIS, radiation exposure, DES exposure, and that was a medication that was used to prevent miscarriages back in the 1940s or 60s. So if your mom used those at that time, you may be at increased risk. Early menses or late menopause, higher birth weight, having dense breast tissue, certain elevated hormones. And then I put an asterisk next to the last two because these may or may not be modifiable. Having your first child over the age of 30 years or never being pregnant, because that may or may not be in your control. So some modifiable risk factors. So I modified this chart from Susan G. Komen's website, and they break down risk factors based on the evidence. So the probable factors, the best evidence that we have that there's likely an association, possible factors that there's some evidence for, but they kind of need more research, but there's and then insufficient evidence. So where there's not enough evidence or not enough studies right now to say that there is an association or there isn't, kind of thing, kind of wavering, or their research is being done. So highlighted in green are associated with decreased risk, but the rest are all increased. So the best evidence we have for factors increasing breast cancer risk includes smoking, use of birth control pills, increased alcohol, night shift work, increased postmenopausal BMI and weight gain, and some decreased risk for breast cancer would be breastfeeding, increasing fruits and vegetables, and increased activity. But I just want to make a note that even though, so for instance, use of birth control may have some increased risk of breast cancer. This risk after you stop birth control kind of goes back to average risk, and you've got to kind of look at the pros and cons of using birth control. So I just want to throw that out there. And then some modifiable factors that are not associated with breast cancer. So these are kind of more myths to be debunked, that there's we have pretty good research to say that these do not affect breast cancer risk, like underwire bras, implants, caffeine intake, cell phone use, deodorant, estrogen-only hormone therapy, trauma to the breast, or even left-handedness, which I had to look this up. And left-handedness, this theory came about because there's a slightly higher incidence of breast cancer on the left side. So they postulated that if you were left-handed, that increased your risk, but that has since been disproven. So there are many potential modifiable risk factors, but the strongest evidence that we have would be avoiding weight gain and obesity. So maintaining a healthy BMI of 18.5 to 25, or waist circumference less than 31 inches. Maintaining adequate physical activity, the goal being 150 minutes moderate activity a week. Minimizing alcohol intake, and getting adequate fruit and vegetable intake, which that equates to 3.5 cups a day. So World Cancer Research Fund and the Academy of Institute of Cancer Research, or American Institute of Cancer Research, they developed a score based on these risk factors, in addition to breastfeeding and limiting processed foods and sugar sweetened beverages. So they've done a lot of research based on these lifestyle modifications. And so one study I just wanted to highlight, in 2016, it was published, prospective data from over 30,000 women. They're mostly primarily postmenopausal, and they followed them for over 15 years. And within that 15 years, about 1,300 of them developed breast cancer. And those that met recommendations, 6 to 7 recommendations, had a 51% lower risk of breast cancer compared to those meeting 2 or less. So, which is pretty significant, that there is a correlation between the being healthy and breast cancer risk. So their statement is that over 30% of breast cancers can be prevented. And that's actually only following the exercise, the fruit and vegetable consumption, and the healthy weight guidelines. So that's not even including smoking or alcohol risk factors. So pretty significant. So just to touch on physical activity, recommendation is up for 150 minutes of moderate intensity a week. Moderate intensity like brisk walking, swimming, dancing, or you could do 75 minutes of vigorous intensity, and that's more higher impact aerobics like jogging or running, but just getting your heart rate up a little higher. But also incorporating muscle strength exercise at least twice a week, and that's really important to help preserve the muscle mass and bone health, which is so important the older that you get. So even if you can't follow these guidelines, there's just such an importance of avoiding sedentariness. So that is basically independent of meeting these guidelines, is in increasing your breast cancer risk. So moving more, you don't have to necessarily meet those, going to the gym, but it's just getting up every hour, and the less time you're just sitting is very important. So some final tips just based on everything, is basically stay up to date on screening. We've definitely stressed the importance of annual mammograms and not ignoring any warning signs. So, communicating with your doctor and getting your imaging, getting examined, and then staying healthy. So there's a lot of things that you can do to decrease your risk, but the most important thing is just eating healthy and getting regular activity. So they're often underrated, but they can make a huge impact. So a few resources I also wanted to include. Environmental Working Group is just .org is just a good site for kind of reducing your environmental toxins and kind of clean living. It's a good resource for that. MyFitRx is a program we have through Northwestern at Huntley, where you can get a physician referral for like fitness. Basically, you sign up for an 8-week program, and they will do customized fitness tests and give you a kind of exercise regimen to do, and that's kind of focused for cancer fitness, for guided movement to help kind of your prognosis or just how you're feeling, your muscle function, range of motion, all that. And then the healthy10challenge.org is free to sign up on their website, and they kind of send you goals to kind of help you move more, eat better. So they'll be sending you recipes and tips through the 10 weeks. So it's just kind of a nice resource, a free resource that you can use to get more information. And that's it.